Good afternoon, friends. First of all, many congratulations to IIP Valsad branch for this wonderful organization, and welcome you all as a Pediatric Infectious Diseases Academy Secretary to all of you this particular VACCIIDCON. So today what we are going to talk about is achieving long-term protection against pertussis, and this is really a topic of concern for everyone since I think last decade. We know that we have a WP based vaccine which was there in 1940 and it worked very nicely because the incidence and disease prevalence went down very drastically with the involvement of this particular WP vaccine. But then, you know, the controversy in a hot debate, you know, we know that Nitin Bhai must be witnessing, because we had been, for every conference this topic was a hot topic for debate, and there was tug of war, which is better, WP or AP. And we know that yes, WP has served the purpose initially, but what happened? That there were growing concerns with WP vaccines. So there were, you know, some perceived concerns about the safety and potential side effect, and maybe suspected neurological complications. And also there were some, you know, suspected cases of post-vaccine febrile seizure, which now we are just correlating with Dravet syndrome. So that was there. So ultimately what happened, it went to the, from science to media, and ultimately it became a very hype, a media hype was there. So what happened like in 70s and 80s, because of this particular media hype and this discussion about this safety issues, and vaccine coverage went down drastically 10%. And because of that, what happened, there was dramatic increase in annual incidence of pertussis to a level even before the introduction of pertussis vaccination. So then what happened, that in response to this particular apprehension associated with DTWP vaccine, there was a definite need to get some safe vaccine or some less reactogenic vaccine, and that endeavor we came up with a DTWP vaccine. And Japan was the first company where this 1981 this AP based vaccine was introduced, and then there was licensing for the 1 to 5 component AP vaccine in North America and Europe. So most important message is the AP vaccine were conceived, delivered and nurtured because of perceived reactogenicity of WP vaccine, but not the perceived inferior or less effective vaccine. So that is very important. So what is the basic difference between WP and AP vaccines? We know that the major difference between the hexavalent vaccine, which are having either it is having a WP component or a AP, where 2 or 3 or 5 components are there. Now WP is containing almost more than 3,000 antigens. We know that almost 10 around antigens are very important. Out of that, 2 to 3 are maximum 5. They have been taken in the acellular pertussis. So this is a basic difference, WP versus AB. But when you see the efficacy, there is a comparative efficacy of the historical WP and AP vaccines in 3 or 4 schedules, dose schedule. So what has been found, that almost all this WP and AP, they performed very well, particularly short-term immunogenicity. For 2-3 years it was performing very well. But there was very interesting finding, which you can say Senegal study, where the WP of the Sanofi and AP of Sanofi were just, both were compared, and what we found was WP based vaccine was 96% efficacy as compared to 86 of AP based vaccines. So then vaccine effectiveness was to be considered, that across the 3 or 4 valid DTWP or DTAP doses versus no vaccination. So really the vaccine works or not, either AP or WP. So there, this particular study was there in the United States, where young children 6 months to 59 months were studied, and what they found, that vaccine efficacy or effectiveness was in the tunes of 95%. So whether you use AP or WP, when it goes to the ground, that it performed well. So vaccine effectiveness is very good. So now then there are the cases, and latest is recent pertussis outbreak in UK 2023, where they were just studying that every year, maybe in July to November, this 5 months, what were the numbers of reported cases of whooping cough, and over a period of last 3 years, what they found, that number were increasing in the tunes of double the numbers. So there was a concern. And also we know that we have been discussing this Jefferson pressure paper, that there were pertussis outbreak were reported from regularly from many countries like USA, UK, Australia, Chile, Brazil, Colombia, Pakistan. So most important thing is pertussis resurgence, war outbreak, it is multifactorial. It is not only because there is a decrease in only the decrease in coverage or waning of immunity. But there are few important things, the plausible causes of increased incidence of whooping cough in last decade. So what they found that there is evolution of the Bordetella pertussis. Second thing, definitely the waning of immunity is an important factor. Also the B pertussis transmission by asymptomatic carriers, and of late we have improvement in pertussis surveillance and as well as in diagnostic methods. So there may be many reasons for which this particularly resurgence has been noted. Now there are two particular countries where this interesting studies were there. One is US and one is Australia. So pertussis outbreak which happened in Queensland, Australia in around say 2011. So there was highest incidence between 6 to 11 years of age. So there were cohort who were vaccinated either with WP based vaccines or AP based vaccine. And what they found that those cohort, that cohort which was having a DTAP as a primary course was having a higher annual rate of incidence with pertussis rather as compared to WP based vaccine. So that was one thing. And then there were different group, rather cohorts, where either they were given all WP vaccine or they were given all AP based vaccine, or there was mixed. AP was given first and then WP, and WP was given and then AP. What they found? The pure DTWP based primary course was having a least reporting of the cases of pertussis. Highest number was from the children receiving a mixed course, where particularly first dose was AP based vaccine, DTAP based vaccine. And what they found, even if the first dose of DTWP was given in that mixed population, that was lower as compared to pure DTAP or a mixed course of first dose of DTAP. So DTWP primary course confers the long term protection, thereby prevents the pertussis, and even a one dose of DTWP vaccine given as a first dose makes the difference in immunogenicity. So this was the finding. Then again, which I was talking about the US cohort, there they had different cohort. One is acellular only and other was WP based vaccine. What they found, that a wholly acellular pertussis vaccine series was significantly less effective and durable than one that contains at least one dose of traditional whole cell vaccine. So this was very interesting, and because of that, the IAP Guidebook 2018-19, they say that current evidence is tilted in favor of WP vaccine as far as effectiveness of the pertussis vaccine is concerned. So now the question is how long the immunity lasts, and we know that there is a waning of immunity because of either natural infection or WP or AP. So what is exactly? So what was found that DTAP, like AP based vaccines, there is a waning of immunity 42% every year. So if you calculate like that, then by the time the 5 years happens, there is only 11% effective. The vaccine is effective 11% at the end of 5 years. So if you see WP and AP and natural infection, in general we can say natural infection median 8 to 9 years, WP maybe around 8 years, and AP around 6 years. This is roughly. Now this ultimately brings to the conclusion that there is a definite real concern of waning immunity with AP based vaccine. The odds of developing pertussis were 5 times higher in teenagers who received 4 DTAP courses in their infancy than those who received same number of DTWP. That means the long term immunity is not there, because when these children they grow up, the previous vaccine which is given WP, it is definitely better than AP. So the Purple Book has mentioned few of the points. The studies to date indicate that AP based vaccines are more effective than low efficacy WP vaccine, but may be less effective than the highest efficacy WP vaccine. We know that WP vaccine can be a high and a lower efficacy. At least 5 trials found that WP vaccine had a greater efficacy than AP based vaccine, and many trials which have been done later also hinted that the efficacy of AP vaccine may not be as robust as reported in initial studies. The priming with WP is more effective in sustained prevention of pertussis disease than AP vaccine, and a wholly AP vaccine series was significantly less effective and durable than one that contains at least one dose of traditional WP vaccine. So why this difference in protection? Naturally it has to be doing something with different immune response triggered by WP and AP. Now what are the reasons for difference in protection? Let us try to understand. Ultimately, it comes to immunogenicity and immune system. We know that there can be innate immunity, there can be T cell, B cell, then memory cell. So these everything comes into consideration. So let us see what is the innate immunity. It is immunity. This has to be stimulated because it is getting stimulated in the natural infection. Second thing is T cell response. We know that Th1 and Th17 response is better than Th2 because Th1 it is important particularly for intracellular organism, and pertussis being intracellular, it is very important for this particular Th1 response. Then let us think about B cells. They have been producing antibodies. In that, if you have IgG1 and 3, this particular subtype, it gives a more better protection as compared to IgG4. Now this particular IgG1 and IgG3, it has been neutralizing antibodies. So it is very important to have this particular group of antibodies. Then we have to have a TRM, that is the memory cell which have been there, CD4 count, which have been found in the respiratory tract as well as nasopharyngeal area, which protects the person from, once they get the infection, that pertussis organisms have been cleared up at that particular. So they are neutralizing that antibody or the antigen at the site of entry. And that's why it prevents the nasopharyngeal carriage as well as the transmission. And we should have a long-term B memory cell responses, which will definitely create a herd immunity also. So what is about T cell? See, a large body of evidence now shows that there is a significant difference between the immunity induced by two different types of vaccine currently in use, that is WP and AP. Second thing is, the main difference is AP induces Th2 responses while WP predominantly does Th1 and Th17 response. The immune response resulted after WP vaccine that mimics the immune response after natural infection, which is the best thing to have. So natural infection and WP induces Th1/Th17 dominated response. Now why this is important? Because this Th1, Th17 that results in formation of the specific tissue resident memory T cell, and that is particularly found in upper and lower respiratory tract. And this particularly the TRM cells, they produce IL-17, and that accumulate within that upper and lower respiratory tract, including nasal cavity, and this results in clearance of the Bordetella pertussis. These TRM cells, they play very critical role in long-term immunity. That reduces the transmission and it maintains the sustained protective immunity against the pertussis. It significantly reduces the pertussis loads in the nasopharynx, and it provides the protection against colonization as well as a reinfection, and thereby it prevents the transmission. So when you compare it with AP based vaccine, the AP based vaccine only protection from the symptoms of the disease is offered, while it is unable to shorten the B pertussis dwell time within the nasopharynx. So it does not prevent the transmission to the non-infected, and it is insufficient for inducing the local response to infection and counteracting the persistent burden of the B pertussis within the upper respiratory tract. So AP vaccine does not induce Th1 response, and there is no formation of TRM cells. So now let us talk about the priming. So if you have been primed with the AP, you have been given an AP based vaccine and there is a priming with AP only, what happens? It generates high level of antigen specific IgG4. What we require is IgG1 or 3, but IgG4 is not required, but because it doesn't bind to the complement, it leads to suboptimal inflammatory response. It causes impaired phagocytosis and antimicrobial defenses. So AP based vaccine, if you give repeated boosters, it is underperforming day by day. So you know that Tdap we give at 10 years, it gives protection maybe 2 to 3 years, and there is a waning of immunity. While AP boosters in WP prime, there is a better opsonization, phagocytosis and complement mediated cleaning through the preferential induction of IgG1. So that is very important as far as the protection is concerned. So now just understand that WP based vaccine was given and they were primed with WP and then boosting with WP. There will be interferon gamma and interleukin 17, and this will give better Ig1, Ig3 response. While if you have given AP and then if you give AP or WP, there is a weaker interleukins and no TRM, no memory cells. So ultimately there is a weaker induction of germinal center and less number of memory cells. What they found, those who have been given WP or AP, they studied and they gave Tdap vaccine after say 20 years. And they tried to see what is happening.
To speaker, we are left with 5 more minutes.
Thanks. What they tried to see what is happening to them about the memory B cells. There were less number of memory B cells which were found in those AP given and then they were primed with other things, WP or AP. But if they have been given WP primed and then they were booster, it was more memory cells. So now the concern or the fulcrum is going towards the WP priming. So how can we do that? At least one, ideally the first WP vaccination offers a better protection against the pertussis versus a schedule that only consists of AP vaccine. The duration of immune protection of AP is insufficient and regardless of schedule and number of doses, increasing number of AP booster provides short lasting and rapidly waning protection, and priming leads to faster and stronger stimulation of memory B cells and it leads to induction of antibodies with a broader antigenic and isotypic diversity. So priming really with WP makes the difference. There are few countries where the mixed schedule have been going on like this: Bahrain, Jordan, Mexico, Oman, Panama and UAE. So now let us talk about the original reason why this particular vaccine was brought was the reactogenicity. Whether it is acceptable reactogenicity or not. We know that AP based vaccines are definitely far superior than WP vaccine as far as the minor reactions are concerned. But like a fever or erythema or swelling. But when we talk about the severe reactions, the confidence interval is very wide. So there is, and basically the incidence is very low. So the absolute risk difference between is comparable to WP because such events are very rare with both. So that's why the side effect part is not being considered much as far as WP is concerned, because we have been vaccinated with WP vaccine and even Government of India is vaccinating. Hardly we find this serious adverse reactions. So now there is one interesting finding that in UK they were giving 3 doses, 3 months, 5 months and 9 months. Then they shifted to say 2, 3, 4 and 5 month schedule. So the difference was initially they were giving with a gap of some months and then they were giving at a shorter interval. They found that the reactogenicity was less, and so WHO position paper clearly says the reactogenicity of WP vaccine is significantly reduced when given in early short time frame it's a schedule. And we know in India we are following 6, 10, 14 and that's why we are finding less number of WP vaccines causing this severe reactions. Now hexavalent vaccines have been tried till now. We were not talking about the booster. Now there is a phase 3 booster trial in India which is been showing the immunogenicity and safety. To conclude, there are two vaccines, WP and acellular vaccine. As we discussed, WP vaccine is Th1/Th17 profile, which is functional tissue dependent, tissue resident memory T cells in lungs and nasopharynx. While acellular, it is more of T2, that's why it is having a less of memory cells. B cell response, opsonizing and neutralizing IgG antibody, that is IgG1 and IgG3. While in case of acellular, these are less and IgG4 is more. Protection against disease, yes, short term both are good, but when it comes to long term protection, definitely WP is better. Bacterial clearance, that is sterilizing protection, rapid and high level of clearance of pathogens from nasopharynx, it occurs with WP as compared to acellular, there is failure to clear this from nasopharynx, and that's why the transmission risk is low in WP as compared to acellular where is having a high. So immune response, of course, it is not durable with the acellular pertussis. Even a 1 dose of WP, preferably the first dose in primary series, elicits a superior response versus all AP doses. And common adverse reactions are higher with WP vaccine, but absolute rates of serious or severe adverse reaction are higher with not higher with the WP vaccines. And overall, when we say that WP containing hexavalent vaccines are superior to AP and AP containing hexavalent vaccines. So finally, vaccination do not save the lives, but vaccine do not save the lives, but vaccination do. So whether WP or AP, we should be vaccinating, but we know that WP is having a edge over the AP vaccine. Thank you so much.